History present illness. At the age of 1 year, the patient developed intermittent fever of 3 days duration with pallor and dyspnea. His parents sought medical advice, investigation were done, and he received baked RBCs. Since then, he was maintained on regular baked RBCs transfusion every 2 months. At the age of 2 years, he developed bleeding gums and pouch patches all over the body. Laboratory investigations were done showing low platelet count. At the age of 4 years, he developed severe headache, disturbed conscious level, and left-sided weakness of acute onset. MRI brain showed intracranial hemorrhage. At the age of 4.5 years, he started to develop attacks of generalized tonic-clonic convulsions, which weren't investigated, improved by levetiracetam, which was gradually withdrawn over 1 year to be stopped at the age of 8 years. At the age of 5, he started to get regular platelet transfusion in addition to the baked RBCs. At the age of 13 years, he started to develop hypertension, polyuria, and renal impairment, for which he started conservative management. In November 2021, he became oliguric with puffiness of eyelids and bilateral lower limb edema. He was then referred to our hospital to start hemodialysis. Family history: no family history of similar condition or hereditary disease. The mother is para4+2. He has 3 elder sisters, completely normal. 5th pregnancy was intrauterine fetal death at 7 months. At 7 months of pregnancy, and 6th pregnancy was first trimesteric abortion. Examination at presentation: general examination, pallor, no jaundice, no cyanosis, weight and height, low percentile, normal vital data, chest and cardiac and abdominal examination were normal. Neurological examination: patient has circumduction gait. The power on the right side grade 5/5 and the left side grade 3/5. As regard reflexes, deep reflexes, as the right side has hyperreflexia, elicited patella and adductor reflexes, positive ankle clonus, and also positive Papinski. Investigations at presentation: CBC, total exotic count 5.2, hemoglobin 8.3, normocytic, normochromic, RDW 14.9%, platelet 5, retics 1.8%, total bilirubin 0.4, indirect 0.3, and LDH 513. Blood film has no schistocyte and no evidence of malaria. Serum iron normal except high ferritin 2800, negative direct and direct combs, negative ANA and tDNA. Pelvic abdominal ultrasound. Post kidneys are small in size, preserved corticomedullary differentiation with increased cortical echogenicity. Bone marrow at the age of 2.5 years showed congenital dyserythropoietic anemia. And bone marrow done after referral to our hospital, showing erythroid series mildly depressed with defective platelet separation suggestive of peripheral platelet destruction. Bone marrow refined, mildly hypocellular, and no infiltration. Echo, mild tricuspid regurg, mild left ventricular hypertrophy, ejection fraction 64. Sequence of events: anemia and regular blood transfusion since the age of 1 year, thrombocytopenia and regular transfusion since the age of 2 years, and the bone marrow which showing the dyserythropoiesis, renal impairment which started at the age of 13 years. Combining these events and the consanguinity and the history of abortion, the hematological and nephrological discussion ended up sending wall exome sequencing. It's TMA. There's no evidence of microcytic hemolytic anemia except for increased LDH. There was normal retics, no schistocytes, and neurological markers normal. There was thrombocytopenia. Organ affection, renal and neurological, but the neurological was due to intracranial hemorrhage, not thrombosis. There was no temporal relationship between anemia, thrombocytopenia, and the renal impairment. And out of surprise, the genetic study showing autosomal recessive ADAMTS13 deficiency, which is consistent with Schulman syndrome. After the result of genetic study, he started regular plasma transfusion every 2 weeks for 3 successive days on a dose of 10 mg per kg. Comparison between CBC before and after plasma transfusion. The significant difference was in platelet count before transfusion 5, 13, 17, 21, and after transfusion 100, 282. There's a contributing factor in hemoglobin level, the renal impairment here. So there is no big difference or a significant difference between before and after transfusion. LDH before transfusion 513, 497, and after 212. I would like to express special thanks to Dr. Sarah Mikkaya, the Assistant Professor of Pediatric Hematology, for following the patient and sending the genetic study. Thank you.